us, they'll just indicate the question number that they responded to and how they reflected on it.
Okay, thanks very much, Chairperson. Table 6, we dealt with question number 2. Apologies. Our question is question 2. What HIV messaging is critical to communicate and to who? The sub-question is, how do we reach and empower adolescent girls and young women? And where should we focus and how? So we said, because we are talking about young people, first and foremost, we have to think the way they are thinking. And we also have to move with times. And as we can realize that youth of today is no more be acting or doing things the same way as the youth of the previous times. So we said we still have to go back. Okay, briefly let me take a background to say, previously we know that they were messaging and they were talking about HIV, whether prevention, whether testing, everywhere. And that has sort of slowed down. So we are saying we better go back to looking at the places where we find young people, where young people are getting more joy, more vibe to be. We're looking at the entertainment where we say it's better to reach at them, at those entertainment spaces, and making sure that, for example, if there's something like what we said, festivals and those all white, whatever that they attend, and the Dukes on Flicks, we make sure that we have a messaging at that platform, sort of maybe getting something like a banner, like with all the messages around the HIV/AIDS prevention, the treatments, and also encouraging behavioral changes amongst them. Also, we also need to go digital, as looking at the social media platforms, where we also said within those very social media platforms, we have to check which areas do they like most, even if it's about TikTok, about Instagram, what exactly do they look for in those platforms, and make sure that for every one that the young people likes, we promote something like an advert, pop-up messages that if they are going to look at the dance competitions within is the TikTok? They've asked the elderly to present for the young people. So yeah, whenever they open those platforms, there's something that pops up that's talking about HIV, STIs, and prevention messages or social behavior changes. Okay, also the peer-to-peer conversations. The other thing that we thought of, which is mostly coming up now, is the podcast, that maybe there should be some podcasts where the subjects that are handled are around the prevention, the treatment, and the viral suppressions and the behavioral changes. Okay, we also thought about the churches, because some youth are mostly in those religious spaces, targeting them, because within the very same churches there are peer educators that can be trained and be encouraged to work with them, especially on those religious camps that they are attending or the conferences. Then empowering with resources, looked at something like our point system. Okay, we took advantage of Dreams sitting here, looking at what they are doing at the present moment. They as they are registering all their clients digitally, and they are kept in their systems, and as much as they are accessing the services, there's the point systems that they are collecting points, and at some point they can use those points either for things like data, sanitary pads, and then, yeah, that, and then the role model, we spoke mostly about the social media influencers, and also the peer ambassadors. And we also said, when looking at those social medias, it's critical to check and have maybe a conversation with those social media influencers so that they can send the proper messages, the messages that will also benefit our programs also. And yeah, even this, remember, we have events within all the departments most of the time, because we were looking at the finances, because sometimes the social media influencers, maybe if you say somebody must do a 2 minutes, 5 minutes clip for what that person might look for money. But we were also saying during the events, there are quite a number of entertainers and those influencers that are used. Maybe we can include within whatever they are going to perform, and ask them to also include something like edutainment around testing, treatment, and viral suppression. The last question was saying, yeah, this was the most difficult. Has U equals to U being successful in the province? What could be done to further this campaign? This was very heavy for us because we thought maybe somebody can help us to understand, or is U equals to U being accepted within the province? Has it been embraced, and has it been launched? Because we think those are the things that can assist, and so that first it has to be accepted, it has to be launched within the province, and so that there can be messaging that can be sort of publicized around U equals to U, so at all platforms. So thank you. Maybe we can be assisted on that one. Thank you. Sorry?
Okay, colleagues, so the issue of addressing U equals U, we can address it when it's your turn, but I just wanted to her to introduce herself and the organization that she comes from before we move on to table number 4.
Okay, thank you, Chairperson. My name is Puselezo, my surname is Mohapi. I'm from PEPFA. I'm the PEPFA provincial license supporting Northwest.
Okay. No, thank you so much. We will move to table 4 and then table 7 will follow afterwards. Thanks.
Good day, colleagues. My name is Ethel Maselesele and I'm from Social Development. I am with Right to Care, the Oram Institute, CDC, Margaret, and yes. So we were responding to question number 4, which talks about success and challenges in reaching youth, women, and other populations. And the first question, it says, how do we influence changing patterns of prevalence among adolescent girls and young women? And we talked about programs that mostly are developed for the target group without them. It's not all of them, because we are having other evidence-based programs, social and behavior change programs, but because of resource intervention for impact versus the high targets that are set, it compromises the quality of those programs that we are implementing. So we need to ensure that quality messaging in our interventions. How do we better coordinate efforts on health intervention strategies at local levels in South Africa. We acknowledge that so much work it is done, but we need to integrate our services. We made an example of the model that Dr. KK Ramotosola, I'm giving you badges. The model that Dr. KK is implementing, where you are having all the stakeholders in a room when you go to your event, that there is no service provider or a government department that go to a community alone. And because of that integration and the accountability, Ramotosola is here. If a department is not there, if a service provider is not there, because he knows them, he calls, where are you? We are in a meeting, because each and every service provider needs to account. So we need to improve on integration of services. We also need to improve on follow-ups and also to decongest facilities. The other issue is integrity of healthcare providers. We talked about the attitude of individuals that prohibit communities to be able to access services within their localities as well. We talked about being client-centered in our interventions, to say that if a client can choose to say, as much as I'm staying next door to the clinic, but I don't want to receive my service here, that we need to be able to cater for what the client is saying. But sometimes we know that it is because of the attitude of the professionals that are providing services that are a barrier to ensure that our communities are able to economically access services. We talked about the quality of care versus the numbers of which link to number one, linkage, successful linkage to care and referrals. If we do not know each other as stakeholders, and if I'm referring a client to Home Affairs or to SASSA or to health, and I'm not referring to a specific person, I'm just referring randomly, I have not engaged anyone to say, I'm having this kind of a client, they're in need of the service, can they come, when are you available? Then where I am referring to, they will not be able, they don't expect that person. So sometimes that person is lost along the way, because there is no person who's going to say, our person, our client did come, we were able to do this and this and this, so that there is continuity of care in that person's life. Also, we talked about improving of mapping. And we are saying that some work is done, but we need to improve on that, because when you are having developmental partners come, because they're having a mandate of a certain service with a target, they are going to find an easy way, or where there is a huge number. And we have seen even in our stats, it was presented, rural of rurals and farms, they are disadvantaged. So in our mapping, there is also need to be improving to go into rural areas. Oram, they are here, they are having resources. They know local facilities they don't have to be able to reach those further areas. So we need to ensure that as partners they come, we are able to direct them where services are not congested as yet. Number 3, how is HIV testing and status awareness at and viral suppression seen in your community? Yes. Okay, we talked about the fact that when we are having, if I'm in a relationship with my partner, when I am HIV negative, they take themselves as HIV negative. So they will test, So we need men to be able to access healthcare services. And it does not necessarily need to be good clinicking. It can be good doctoring or our developmental partners. But we have realized, because we have been having engagements that are led through the House of Traditional Leaders, where we are engaging in communities to say sometimes the message that we carry out to communities, it does not really reach men in their simplest understanding so that they can be able to apply it in their lives. So we are having men engaging in the safe platforms. We are providing your men championing change programs, your men sector program. We also talked about the happy hour for men, but the challenge is that men would mostly likely want to engage with a man. And in some instances, we don't have sufficient male clinicians or sufficient facilitators who are males so that they can be able to just pour out their issues in a manner that they don't think that we will impose our views as women. Okay, I think others, maybe 1 minute if I'm missing something. Good. Others, they will come on writing. Thank you very much.
No, thank you. And then just to slap the team and the team that presented before. So just to note that the presenter should just stand up so that they are able to be seen by the colleagues that are also connected online. And then you just need to introduce your name, your surname, and the organization that you come from, and if possible, just the organizations that are represented in your table. So we are going to have table number 7, and then we don't need to repeat what is already been said, just something new or different from what was mentioned, and then we'll take the table that is ready after table number 7. Thanks.
Good day, everyone. My name is Yokhomodi Tlhagane, and I am from Office of the Premier. So the question that we are addressing is, what needs further strengthening in the province or district program? So we have used the questions as our guidelines, but like we have other issues which there aren't any sub-questions about them here. So the first one that our team has noted is that attention needs to be given to the 15 to 19 age group, as these are our teenagers, high school, and the future leader or society. So DOE, in collaboration with health and NGOs, need to be involved. HIV and HPV needs to be taken to schools. So our second point is, the problem is that partners come and go. This is a big problem because they start very nicely, but then they are not sustained. The same situation is with the administrations, as they come and go and programs are not sustained. The third one is, there are programs that concentrate on school-going kids, but what about the out-of-school kids? Of the 8 people in this table, only 2 knew of the DREAMS program. Apparently there's like a DREAMS program for girls. So boys, do we have anything that is like more targeted to boys at the age of 18 or 15 to 24 years? I don't think we do, but only 2 of like our members knew about DREAMS program, which shows the poor advocacy of the program. We need a DREAMS for boys program targeted at 15 to 24 years old as well. There are limited programs available for those not engaged in sexual activities as well. Our next point is, funding for outreach campaigns has decreased. What is needed is prevention campaigns, regular HIV testing, at initiation and adherence campaign. People, communities respond better to campaigns Campaigns can be in malls, parkings, schools, social gatherings, events, and churches as well. Program or campaigns need monitoring and evaluation to ensure that proper spending is happening, no corruption, and the proper work has been carried out or delivered as well. DOE, DOSD also need to budget for HIV programs. Okay, there must be better coordination between DOH, DOE, and DOSD when it comes to HIV. A lot of times we find that it is quiet in our province when it comes to HIV campaigns, but I think it is because that there are limited available funds for such campaigns, so we do need like more organizations to fund for these campaigns as well. We need to strengthen our cross-border health programs to target the truck drivers as well, the incoming and outgoing of the trucks. Parents need to be empowered or well-trained to be able to also have a transparent relationship to talk to their kids about these situations or issues. Also, we have a problem with Dr. RSM district does not have partners nor partner programs. This is a gap. It is said that it's because of the data, but the people of RSM work in other districts and come home to Dr. RSM. It also the most rural district in NW. So yeah, that's all, thank you.
Thank you very much. Another round of applause. I wish Treasury was here to listen to the issue of funding. Any table that is keen to present, that is ready? Oh, 7 hands in this table.
Good day, colleagues. My name is Namezo Segomoto. I'm from the Northwest Department of Health. Here in our team, we are having a rep from a mining sector, a rep from civil society, a rep from University of Northwest, and a rep from Office of the Premier. So we were addressing health. I've mentioned health. We are 2 from health in this group. We were addressing number 2, and the question was, what HIV messaging is critical to communicate and to whom? And we have 3 sub-questions that we were expected to respond on. So I will just go to number 2, and I'm happy that most of the issues were covered by the latter speakers, so I will just go straight to the ones that were not mentioned. Before I go to number A, as a team, we've agreed that it's time that we include boys, like you've just said, in our interventions. Because based on the statistics that was presented in this meeting today, we've seen that somehow the statistics for boys and men is actually going up. So meaning that we need to come up with both interventions or targeted interventions for both boys and girls or young girls. So, and then we also agreed that we need to strengthen multi-sectoral approach when dealing with our young people in the province and do away with a silo mentality. The other thing, we've also mentioned that, like I've said earlier on that, like you said, that already we're having programs that are in place, meaning we are having messages in place. We're having Dreams project that actually you've seen that it has been working in the province or across South Africa and other countries. So meaning that messages are there. HIV prevention messages are already in existence. So but the issue is the approach on how we communicate the available messages, HIV prevention messages. So I will be going straight to the key interventions, others were mentioned. We talked about that it's time we include activities like music, drama, and use of pictures to communicate messages. We agree that, most especially in our province, we've been mainly focusing on events, dialogues, and other interventions. But it's time we strengthen these other ones that I've mentioned, because others were mentioned by our colleagues in the meeting. So under number A, they are saying, what are the implications of shifting pattern? Number A, ours is 2, ne? How do we reach, pardon me, colleagues. Ours are, how do we reach and empower adolescent girls and young women? Where should we focus and how? So as a group, we've agreed that we need to empower them by ensuring that we include them in our activities. So, and then our empowerment has to include the eradication of poverty, job creation, and allow or encourage young people to be independent. Secondly, we said we need to use young people to reach young people. Normally, they will be saying nothing for us without us. So meaning those dramas and everything, they have to be led and be done by the young people. And then we need to focus on areas where we can find young girls. We've been debating on this one of churches to say, when you go to most of the churches now, unfortunately, you'll find out that our young people are few in churches. So meaning we have to go out and find them. So where do we find these young people? We said, okay, they're at schools. And remember, at schools, we are having those ones that are sexually active and others are not. I like what the other group has just said, that we must also develop those messages of those that are not yet sexually active, so that they can also remain like that until they reach certain ages. And then we need to, we talked about the brothels, that yes, I manage the key population program in the province. And most of us, we know what is happening. When you go to those brothels, you'll find 14-year-old, 13-year-old in those brothels. So it's time we focus on such areas. Taverns, you'll find a 12-year-old. You remember an incident that happened, Eastern Cape, 13-year-old, and so those are the places to be targeted. And then they go to youth centers, and remember, some are not functional. And then clinics, they do come to the clinics, but the fortunate part is that in most of the clinics, we're already having interventions for the young people. We've got youth zones and others that others have just mentioned. And then we now go to the other one, number B. Let me mention the other one, or how to empower young girls. We said we need to influence city and town planning to include the restoration of youth clubs and centers that are not functional in our communities, like recreation centers with activities that can stimulate and keep young girls and boys at ease. And we also said we need to influence or change municipal bylaws to restore order within communities. Hence, remember when I started, I said we need to strengthen our multi-sectoral approach, because alone, as we are here working for social development, Department of Health, when it comes to bylaws, there's nothing that we can do, meaning we need to engage municipality so that other things can be strengthened. Because when you go to those taverns, you'll find a 10-year-old there, 12, and then the tavern will be opened at 6 o'clock, 6 to 6. Such kind of things, those are the things that have to be regulated in our communities. And then we go now to the last question. The last question, they were saying, has U equals to U been successful in the province? What could be done to further U is equals to U campaign? So on this part, colleagues, I'll be giving Pastor Moepi to respond to this one. Over to you.
Ale chapel ke nna moruti ke le nosi ka ba. Ale chapel matsogo. All right. This one is a very controversial one. I know it has created more enemies than friends. But what we said from experience and interacting with communities is that this program has been poorly presented and introduced and in the province. And it has been a highly contested terrain, something that also suggests that maybe timing was not right. At the time, while we're still trying to enforce and encourage continuous use of condoms in all sexual encounters, U equals to U came. Unlike MMC, which encouraged use of condoms, this one has been selfishly used to discontinue condom use by these partners. By the way, they don't want to use condoms, and research says they don't even know their status. Even if they know, they are not remaining on treatment so that they are virally suppressed. And as a result, we have these findings and people presenting more with sexually transmitted infections. What we said is that you should have been more about celebrating one's achievement on viral suppression than it is today. It is now more linked to bloating than what it wanted to achieve. And we said 3 key points must be noted. It has not been successful and should be revisited with more clinical assessment on those on treatment. It was poorly introduced, like we said, and messaging about it should be revised and properly crafted. Lastly, it has to be revisited and encouraged, especially for those people living with HIV and want to plan their family, than a generalized approach. Thank you.
Oh, thank you very much. Pastor, the table here was very keen. Oh, okay, let me give these ones, then you'll be next.
Thank you so much, Program Director. Standing here, colleagues, it's Bonolo Mutlomi. I'm coming from Shout It Now. And our table here is having representative from PEPFAR, Dr. RSM, District 8 Council, and myself, Shout It Now, HIV SA, as well as Bojanala, District CSF Chair, and also Office of the Premier. So we were answering question number 3, what needs strengthening, further strengthening in the province or district program, and it consists of 3 questions. What has been the results of voluntary medical male circumcision program, and have youth HIV prevention campaigns been successful at reaching its target audience? And lastly, have HIV prevention strategies for men been successful, and what are the best practices to focus on? Colleagues, I won't mention what has already been mentioned by other tables. I will just highlight some of the things, key areas that were not mentioned by fellow colleagues. So number 1, we said that, as the province, we need to start having conversations with men and just having a safe space where men can just sit as men and start communicating about men issues, issues around HIV, issues around GBV, issues around VMMC, issues around just family conduct, and also them having to advocate for some of the HIV prevention programs within the communities. So once we have those talks and dialogues with men, we know that that is where we need to start, because one thing that we want to achieve is to get men to access health services, and it's been a taboo. And what we know is that men usually want to test with their finding out about their HIV statuses from their partners. And we want to move away from that. And actually, once those dialogues or conversations are had by men, by themselves, they can be able to encourage one another to start accessing the health facilities and actually being advocates as well to younger boys as well. And one thing that we talked about in the table was the issue around VMMC, where we know in the province that we coming from different beliefs of how to do things, and from the data that was presented, we have seen that 50 plus men has actually conducted VMMC through traditional service, and younger men obviously doing, going for the medical way of VMMC. And we are saying that we need to also have conversations with men around that, so that they can also keep encouraging the boys to go via the medical route, because that is the only way that we can know that it's safe for them to go through. And it was also mentioned the issue of reaching out to truck drivers, but we also touched on farm workers, because we know that or we have seen that in the facilities, men, or in the province, men go to farm working. And wherever they are, it's very, they can't access those health care services at the farm area or the rural area. So we are saying that we need to also take, consideration to taking the services to the farm areas. And then we are saying that for men to, get the men to come and to access the services, we need to reinforce our index testing as a province. We need to, maybe encourage or speak and have that conversation. And I liked what the other table was mentioning about posters and, communication, where we just need to not just say it, but also if it's in a picture form, then we can be able to, or posters, they can be able to know that this thing is really possible for myself to test with my partner. And we also mentioned issues around Zikhala Kanjani. We are saying that as a province, we do have very good concepts of getting the youth accessing the services and, communicating. But we are saying that we need to really strengthen that component, because if we just launched and it ended there, then it means that we are really not serving the objective of the main program. And we are saying that also the facilities, we need to strengthen the youth zones, as well as the AYFS services. Colleagues, when we say strengthen, and we are talking about not just me as a youth going to facility and knowing that there's a safe space, but we need to maybe have ideas or things that can really draw the youth to come to the facilities. If it's a gardening service that we need to have in the facilities, let it be that, because we'll know that from that gardening service, a young person or man or whoever that is interested in farming, they can be able to learn from that small little garden at the facility. And the youth of Northwest, we are faced with unemployment, and if we strengthen the youth, youth AYFS facilities, where we can just maybe have, it's one of the ideas that we can have an internet where youth can be able to just source out available opportunities for them, so that they can be able to know where they can apply for employment or other opportunities, whether it be applying at a college or university to further their studies. But something, we just need to do something as opposed to just looking at the health, because those are some of the things that are drawing the youth to come to the facilities. But if we are not addressing that, colleagues, then it means that we'll still have those gaps of the youth not going to the facilities, and especially men. Thank you.
Thank you very much. As a father, the word man keeps on, coming up. As a father, would you really say to your son, do like I do?
Just in time. Good afternoon, colleagues. I hope everyone is still okay. So, in this table, I have with me the leadership. I'm going with the leadership in this table. I have the DDG. I have our chairperson from civil society. I have UNAIDS, and I have USAID, and I have TB, HIV, and care. So you can see this is a table of leaders. So the question that we are tackling is question 1. What are the lessons learned in the province? I hope this is not too much for you guys because I have a loud voice and I usually don't use this. So the first one on the 1, it says, what are the implications of a shifting pattern of HIV prevalence and the aging epidemic? So on that one, as this table, we figured that the presentation there stated and showed us that there's a decline in the prevalence. But then we were discussing what could have caused the decline. Is it change of behavior maybe? Or is it because of the presence of partners? Or is it because of easy access to treatment? So maybe as a team here, when we look at it, we can look at all those issues, whether they are the ones that are leading to the decline. And then we saw again older people being the ones that are living longer, which means that older people are adhering to treatment. And not only adhering to treatment, we saw again that it might be that they now have more access to knowledge than before. And therefore now they access treatment and they remain on treatment, unlike our youth. And then, and it can be very distracting. Sorry, colleagues. So, on that one, we saw again that there has been a shift on 0 to 19, and the presence of HIV amongst those 0 to 14, and this calls for intervention such as PMTCT to be scaled up. And then we still continue on the first one. So we say for those 15 to 19, we need strengthening of programs such as PrEP. We need also programming strengthening of programs when it comes to condom use. We saw there that condoms are not used, especially between the ages of 15 to 19. So another gap or limitation that we saw there is that the study does not cover RSM. It serves as a limitation because the, RSM is mainly a rural area, and therefore in the presentation it was not covered, which then leads to the limitations of the study. And then another thing, we need to improve on retaining patients on treatment, and then we need to ensure that there is adherence and there is viral load suppression, because we saw that, or we see that as a province we are lagging behind when it comes to the UNAIDS 95-95-95 strategy. So there's also a need to develop a longitudinal view of patient medical record to monitor client movement across all provinces. So what we agreed on this one is that if I am a client, I should be able to be seen go Eastern Cape that I've tested HIV positive and I'm from this province and I've been on treatment, or I have not been on treatment. So when I go to other provinces, it should be easily picked up that this is so and so from this province, they previously tested negative or positive, such things. And then the second one said, where do you and your children or community learn about HIV, at school or clinics? So we mostly focused on ages 15 to 19 and 10 to 14. So it means we were looking at youth. And we were saying, where does our youth access information? The answer is most of our youth, they access information in schools because they are there. The age that I've been talking about, 10 to 14, 15 to 19, they are all in schools. What programs do we have in schools that talks to prevention of HIV? In primary schools, there was someone who said, I don't think there is programs in primary schools. Well, maybe there isn't enough, but what we have currently, it's Soul Buddies. So Soul Buddies, it was an initiative by Soul City, but the department then took it over and is implementing it, and it has age-appropriate, scientifically proven information that is given to our learners. And then we also have comprehensive sexuality education, which strengthens life orientation program. Although we're saying we're not referring to the LO when we say teaching learners about HIV, comprehensive sexuality education strengthens life skills, life orientation, because if life skills, life orientation is not taught correctly in the classroom, then we don't have learners that knows that there is sexual reproductive health services that they can access. And then we also have peer-to-peer clubs, which is peer education. That is in our secondary schools. And then all these programs that I'm talking about, they also need to be strengthened. Why? We find ourselves that these programs are run by educators, and we all know that educators are already have a lot on their plates. So this is the programs that needs to be strengthened, because then it means in some schools we'll have educators not being available. And then we know of the integrated school health policy that requires Department of Health, Department of Social Development, and the Department of Education to work in partnership to ensure that school health is attended to in our schools. So with all these programs that we're having in the schools, our children are learning HIV and AIDS information from there. But however, we have seen, we are not yet there. Condom use, very low. Early sexual debut, very high, especially among boys. And I tell you, in our camps, they say, "Hagiji stock sweetie ka plastic." So we are still far on that one. And then parents, where do our parents or our communities learn about HIV? We have partners, but we still believe that that is not enough. We need to bring back parent engagement. We need to bring back parents' dialogues. There were times when we had dialogues with both parents and children in the same place so that we are able to discuss these things. So you find now a parent, motsamaisa tiro ke re la ba itse ko funeraleng ba re. So motsamaisa tiro a re nako e tšhaile. O ntšhutisa se funeral. Then number 3 was men programs. Are they successful? The answer is no. I think most of the tables have presented on that we do not have men programs that are successful. And then my colleague mentioned that there are programs as Mina and Coach Impilo for men. And then at least in Northwest, we have men-to-men done by Shout It Now. But we all know that the programs that are offered by partners, they are limited. So probably our gap here is funding. There is a need for more funding because we can't have partners only in Bujanala. And someone was saying, probably in Bujanala, we still see Bujanala as a district, there's high prevalence. Kanti, it's because of the data that we are now getting, because we have a lot of partners there. So it means we now have a lot of reports. In RSM, we wouldn't know because there's nothing. Thank you, sir.
My apologies. A round of applause. Another table ready. Professor Zuma, it looks like you'll be going back to Pretoria with that present that you were showing me outside. Because thus far, nobody has hit the 4 minutes or less in terms of reporting.
Thanks, Chairperson. Let me do that. I'll do it in 1 minute. My name is Akanyan Didimalang. I'm from Department of Health, Dr. RSM. With me, we have Prof from the university, PCA, and Live. Oh, Laugh Line. Thank you very much. We are doing question number 2. I think most of the colleagues touched on issues that we have noted as table number 10. But the other thing that we also noted, we noted the issue of maybe making programs for young male and young men, of which I think Oslebo clearly elaborated on that issue. And then we also ask ourselves whether do we have adolescent programs or adolescents programs that are up and running. And through our engagement here, we have realized that, yes, we have programs, but we are not reaching out. In the presentation, we saw that there is a rural farm where there are also numbers there, and in some instances, those numbers are very high. So it means we are not reaching out to farms and rural areas, or let me say, the hard-to-reach areas. I think most of the things they were touched by other groups in terms of empowerment. They also touched, except that we said we need to do what is called knowledge, attitude, and practice study to make sure that our empowerment to adolescents and young women are yielding result by doing knowledge and attitude practice study through Facebook. It can be easier if we do it through Facebook, where we will be monitoring their responses in terms of knowing whether is there heavy knowledge in terms of HIV and AIDS, or their programs, their attitudes towards that, and the practices. So, I think things were touched by other groups, Chairperson. I don't want to waste your time. Thank you very much.
Give them a round of applause. 4 minutes on the dot. It looks like the car will be staying in Mafikeng.
Good day, colleagues. My name is Dorothy Ramono from the Department of Education. The question we had was, what are the lessons learned in the province? The first point we had was, we wish that the key populations could be included in such a gathering. And we talked about the sex workers. What we have learned is that they do receive health education, but the use of condom is still very low. And the question was also asked, are we doing much in awareness of how our sex workers should be conducting themselves? And the response was that the sad part is that even the learners that we are talking about, who are from the age of 15 to 19, are also now entering or migrating to the sex worker sector. So it seems like much is done, but more damage is happening to our little ones. And we should also include the inmates, the LGBTQIA, and the drug users. And it was alluded to the fact that in terms of the sex workers, communication has been done with the providers, the clients, and also access to PrEP, so that HIV should be going down. But now that we know that it is all done for all the sectors, we just need more strengthening so that our sex workers are safer and they can live longer. And the second point was our adolescent and youth. We talked about the 15-year-olds to the 19-year-olds. We are saying the Department of Health has activated adolescent youth-friendly services. Whatever they did not receive nor understand in the classroom in terms of comprehensive sexuality education, they are free to go to the adolescent youth-friendly services between 2 o'clock and 14 hours to 16 hours. They call it a happy hour, where we are provided by a very youthful thinking and talking nurse. So most of our children are having time to talk their sexuality issues or even sex issues and HIV issues. We also have our partners like Shout It Now. Through the agreement of the parent body of the school, they are allowed on site to offer services, sexual health, reproductive, to our learners. And the first thing that is expected of them is that there should be consent form signed, so that should anything untoward happen, the children and all of us are protected. We agree that integration of HIV and AIDS is done nationally from our Department of Basic Education through scripted lesson plans. So we are talking sexuality, we are talking transmission, prevention, a decreasing of HIV and AIDS in the classroom. And the last thing that we what is happening in our schools is that all this has been done for our learners, but now the floor is now going to be open for parents and learners to talk sexuality, HIV and AIDS, and prevention of pregnancy under the same roof on the same platform. Thank you.
A round of applause. 4 minutes, 33 seconds. They are just 4 minutes behind table 10. Just 4 seconds, actually. 4 seconds behind table 10. They were almost there.
We are done, actually. Let me prepare myself, sorry. Greetings, ladies and gentlemen, colleagues, all the protocol observed. My name is Mildred Maropefela. I've been coerced to present, actually, by virtue of me being a chairperson. I was coerced. I need to share that with you. I'm not doing this voluntarily. Under duress, my man, under duress. In my team, I've got AFSA, one representative of CSF, NMM, Ngakamudiri Mulema Municipality, Department of Health, and PCA. I think we are the last table to present. So clearly that is given that 4 minutes will be too much because they have already mentioned a lot of things that we wanted to mention. We were addressing the last question, question number 4. We're going to start with point A. Can't we? Okay. Okay. The first question, how do we influence changing patterns of prevalence among adolescent girls and young women? Point 1, we need to accommodate awareness programs on HIV-related issues to the level, to increase the number of awareness programs on HIV-related issues to the level of adolescent girls. Enhancing comprehensive sexuality education, it was spoken about through social media and in the households. Ensuring that there is access to condoms and contraceptions. Strengthening the youth-friendly health services and strengthening economic empowerment. Without economic empowerment, nothing we're gonna do. Peer education support, gender-sensitive health services, especially for women. And lastly, strengthening of the PMTCT. Now, the second question to that was how do we better coordinate efforts on health intervention strategies at local levels in South Africa? And we said we need to get systems in place, e.g. standard reporting template, recruiting people who are representatives of the community to coordinate health interventions so that the refusal of participation in programs/surveys can be reduced. We are talking about community-led activities. And lastly, recognition of NPOs. That will mean funding of NPOs and etc. And the last was how is HIV testing and status awareness and viral suppression seen in your community? And the answer was that there's still stigma regarding HIV despite the awareness programs. There's been improvement in HIV awareness, lots of awareness programs in various activities. Second last, in clinics, there is a line for chronic patients which leads to people stigmatizing the patients based on the assumption that they are HIV positive. Some may not be on ART consistently. Need to know, I thought it was the second last, still going on. Need to know who the target for the intervention is, how to approach them to increase awareness, testing, and etc. There needs to be a youth ambassadors. I think this point has been reiterated many times, who can speak on their HIV status as representatives of youth community, youth by youth. Some parents still don't inform their HIV positive children why they are taking the medication. Children need to be aware of their status too. So I think I want a present. I heard that there's a present for people who keep time. Thank you very much.
A round of applause. Doc, unfortunately, table 8 and table 10, it's a tie. Exactly same time, so we will think how we deal with the present, with the gift. But they presented exactly 4 minutes, 38 seconds, both of them. Colleagues, there is so much that is being done in the province. All departments are doing so much. It is just that we are not there yet. And we do appreciate efforts, programs, projects that you all have in place in partnership with private sector. But we are not yet there. The results clearly shows us that we are not yet there. But this session gives us an opportunity to harvest ideas. Because going back to our offices, we have then the opportunity to say, how do we improve? How do we intensify? How do we innovate to be more impactful? I always argue, we can have minutes, meetings, present our progress reports, 100% achieved, targets, clean audit, all those excellent reports that we present. But the question is then what? What is the impact on the ground? And I think that is one thing that we must always grapple with. To say, in everything, when you wake up in the morning going to your work, come back home with an answer to then what? Yes, you've been in the office, sitting in that nice chair. Wile Sekgowa, you spoke English very well, but then what? How has that translated into changing the lives of the people in Northwest? So, with those few words, I am going to hand over to Doc to wrap up the program as we move towards the end, and thank you.
We're still hoping to end the activities by 2:30, so we really have a tight timeline. But I'm going to ask Margaret to just share some of the reflections on the activities that transpired today. She'll also be joined by Meg Molemani as well. And then I see your hand. I'll just attend to it, but just to allow these colleagues, and then we'll come back to you. Thanks. Okay, as the colleagues are...
How, boss? That's what I got to start again. Good day, colleagues. Good day. Oh, I thought you guys are sleeping. Okay, my name is Judy Molemani. I'm working for the Northwest Department of Health. I am responsible for the ERT program. I'm standing here representing Meg Ristile, the Chief Director. Let me start by saying we thank you, Human Sciences for Research Council. And then we thank you for the study that was conducted. We appreciate the findings that were presented to us here today. We also have heard the presentations as it has been made by colleagues from different tables that are sitting here. As Northwest, we are seeing that there are some inroads and progress that has been made. When you look at the 2017 study compared to the 2022, it means we are going somewhere. We know that as a country, we have actually introduced the ART or the treatment program back in 2004. And ever since then, there have been developments because our ART guidelines have been changing. Since 2004, up until now, last year, 2023, we are having new ART guidelines. where we have actually adopted the dolutegravir-based regimen in the ART program, which was adopted in 2019. Now, with that, we have seen a change. Even with regard to the progress with our 95-95 targets, you can see that Northwest, for all the populations, for the first 95, we're standing at 96%. Now, for the second 95, we're standing at 84. As compared to where you saw in 2022 when the study was made, we're standing at 77%. But to date, we are standing at 84 as Northwest. It means we are going somewhere. And then we can also see that with regard to the 30-95 also, we are going somewhere. So we appreciate these researches that are being made, because they, as they are being presented to us as government, it means it makes us to develop new strategies to can actually address the pandemic. So we can see that we are going somewhere. Now we are seeing that the things have changed, because back in 2017, the most affected population group was the young people, the young girls between 15 and 24. Now we can see that when you look at the sexuality bar, the age group that is most affected now is boys. So you know, sometimes this problem of us focusing in one group and leaving out the height, we have been concentrating so much on the young girls and young women and young girls population, and we left out the boys. So it means now, as government, we need to make sure that we address all the young groups, all the young people. So we appreciate this, and we will act on the report. Thank you very much. God bless.
Thank you so much for that. Margaret, do you also want to share a few words before we move on to the question?
Thank you very much, Doc. Let me take this opportunity to really appreciate our people, from the People's Province, the people of Vukoni-Vupirima, for availing themselves when they were called to come and hear what is happening in the Northwest Province. I'm humbled. I really want to appreciate all government departments, my colleagues from government departments, all government departments, health, education, Office of the Premier, Department of Social Development and Correctional Services that are here, colleagues from the municipality, colleagues from, I've seen someone from Mr. Kim Ernest from Impala Platinum Mines. I'm launching the private sector forum this month. So when you come next October, you'll find a fully fledged private sector forum for Northwest. So I really appreciate that. And to HSRC, you are always there to guide us. When we ask ourselves questions and we do not have answers, you always come at the right time. So thank you for sharing with us the result of the 6th survey on HIV prevalence, incidence and behavior. I do say, like Memory Manager, that we have made strides as a province in terms of where we are coming from, but we should acknowledge that we have gaps that we need to fill, and we cannot fill them by business as usual, looking at the time left for us to be at, to realize the 2030 vision of the United States, of the United Nations, sorry. Now, because I'm focusing on CDC people in front of me, now I'm talking about the United States government, because America is just in front of me. So, of the United Nations. So, I don't want to go deeper into the study, but what I can say, Doc, is that we have acknowledged the gaps that we have with children and adolescents, with boys, gaps that we have with men in terms of us having gaps in terms of ensuring that men knows their status and they are initiated on treatment. Same to young people, that we really need to go out there and look for them and make sure that they are initiated on treatment. And thank you for addressing the issue of knowing your epidemic, knowing your status, because we are giving us some suggestion as to where these people can be, whether in rural or whether in urban or whether in farming areas. But we do acknowledge that in the Northwest, and together we are a team. As you see us here, we would put our heads together and see to it that, as DDG has said this morning, we put together a plan and process it through the right channels to address some of the gaps that we are seeing in this. We are a mighty team, and we believe that together we can do it. I don't want to go deeper into the reflections. Thank you.
No, thank you so much, Ms. Margaret, for going deeper, but not very deep. So before I call upon Dr. Sean Joster, who's the co-principal investigator for SABSSM, I just want to acknowledge the colleague who wanted to ask a question, and after asking his question, we'll just go. Remember in the morning when we started off, we mentioned that we wanted to project the 3 questions that you responded to. We just want to look at your response only to the second question, which looked at the photo gallery. So we'll do that, but just for the colleague to answer the question and just look at how you responded to that as well.
All right. No, thank you very much.
Your name and organization.
Okay, thank you for allowing me to ask this question. My question basically, I'm Pastor Neomwepi. I thought I introduced myself earlier. I'm Pastor Neomwepi. I'm from the AIDS Council. All right. My question basically, it's centered around way forward. Who commissioned this research? What was the intended plan on the findings? Meaning, what did those who commissioned this research want to achieve? Where to from here with this research? I'm asking this question because there are lots and lots of researches that have been done, reports there, but it's like these are reports that are there for any person, whoever is interested in the report and stuff like that. So I wanted to check the value for money, really. Or when we did this research, what did you want to achieve? So that we are able to understand, or out of this room, what program of action must be put together. Thanks.
No, thank you so much for that. So Dr. Joster will also just touch briefly on that as he also does his closing remarks. Just to go back to the question that you responded to online around I'm just waiting for it to come up. I don't know what is happening today with technology here. So we asked, how did the image gallery make you feel? We've had colleagues going to the image gallery itself. We also displayed it here. And we note that some of the colleagues said it made them feel emotional. They felt powerful. They found it to be very engaging. Some of them felt that it made them feel sad. Our history as a country, so it reflected as our history in terms of where we come from. There was a deep sense of sorrow for some of the colleagues, mixed feelings, injustice, amazed at how far we come from and the pride that comes. And I think a lot of talk that we did today was around partnership, coordination, and how do we ensure that we strengthen moving forward, because we have seen what we are able to do when we unite. And then motivated, touching, super happy, hopeful is a word that is also shared there. So obviously these conversations don't just end as we end the program. During lunch, we are going to continue the conversations. We are going to even continue beyond today. We have formed new relationships, and we continue to share new ideas on how we can strengthen the work and partner better even in our communities. So Dr. Yoste, if you can just come in and do the closing remarks. And I've also noted that in the province, the owner or the person that hosts you must also just do the final goodbye and also show you the direction in terms of where you should also be eating and drinking, whatever they'll be serving you. So I'm going to ask our DG, Dr. Mawel, to also just a few words, just as a goodbye, but also just the direction in terms of the province as well. Thank you so much. And just to thank my colleague as well, because this is the last time that you'll hear me speaking on this platform, Dr. Marumo Musenohi, thank you so much for the wonderful facilitation that you did today. We really, really appreciate it. Thank you, colleagues, and have a lovely afternoon if we don't get to speak again.
Good afternoon, colleagues. Thanks, Lelo, for allowing me to just close and say thank you on behalf of the HSRC and also our partners for welcoming us into your province, into the Northwest Province. This study is one of our biggest studies in the HSRC. We call it SABSSM. We live and breathe this study. We have lots of wishful or grand visions of what the study can achieve, but our main focus is to provide information. So since the first study was commissioned in 2002 by the Nelson Mandela Foundation, and the idea was to do it routinely, just to measure because I mean, everyone is doing something in the country. There's lots of interventions, there's lots of things and stakeholders working on trying to prevent the spread of HIV. What this study aims to do is to track that intervention. Where is it working? This study identifies where there are areas that need specific intervention. And I think how the study evolved, in the beginning, we only test for HIV. So we could only tell you this is the prevalence of HIV in the country. That was it. Every time we do the study, and it's done every 3 years, the idea is to improve it, to add more information. For example, now we can tell you what's the prevalence of HIV in the country. We can also tell you how many of those people are newly infected. So we can tell you what's the incidence. We can also tell you now how many people are on treatment. We can indicate what is the viral load. So those things never existed before. And we are so proud of this study. It's the longest study that we are running with regards to HIV. And I think our main aim is to provide information, is to direct, hopefully to direct where people are working, to see, must they make any changes? And we feel that some of the information that came out of the study has led to different types of interventions. For example, focusing on adolescent girls, and we are proud that it came from this study. So it has been commissioned. The first one was done commissioned by the Nelson Mandela Foundation, and with our partnerships now with CDC and PEPFAR, we are doing this every 3 years. There's already plans now to see how we can do it bigger, how we can do it better, because every round we try to improve it and to provide more information that can be used not only nationally, but within the province. And I think as the study has grown, in the beginning we only went to, I think, 10,000 people in the whole country. Now we are even able to talk about districts. We never could speak about districts. So hopefully at the end of the day, after many rounds, we can go to all districts and give information on all districts to help people plan and adapt, how they focus on how to tackle HIV. So that's in brief what our aim was in this study. But on behalf of HSRC and the partners, we would like to thank each and every one of you, both in person and those online, for coming to the dialogues. It's something that we never did before. We're visiting all provinces, and it's nice to see that engagement. But this is not going to be the end of our engagement with you. We are going to share the presentation. So the presentation will be shared with everyone, and that you can share it, with your networks. We're also working on a provincial report, and that will also be shared with the province. It gives a bit more detail not only what was presented in the session, but also more information about your province. And our hope is that this is also a start that will, will improve our relationship with the province, that we can become a better resource for the province, because we're always doing research. Lelo indicated now that we'll be coming back soon to do a study on HIV positive people, looking at the stigma among HIV positive people in certain districts within the Northern Cape. It's not Northern Cape. In Northwest. It will also be a national study, but our hope is that this event and this dialogue is a start of a stronger relationship that can be formed with province and the HSRC. We would like to especially thank the Office of the Premier and the Provincial Council of AIDS, because our team worked very closely with the Office of the Premier and the Council to actually get the invites going, to actually have this event possible. So once again, we would like to thank you and thank you for welcoming us to your province. Thank you very much.
Okay, as Mr. Mawelela is coming through, please scan the QR code here just to respond or evaluate the event. Obviously, as Dr. Jooste has mentioned, this is the first time that we're doing it. We need to look at how do we strengthen it when we come back, possibly with funding, to also do all the districts and everything else that was mentioned today. So it should not take you more than 5 minutes, just to reflect on how the event went and some of the lessons that can be learned. So as you do that, he would also be saying a few words. Thanks.
All right. Thank you very much, Program Director. Yeah, I think it was a very, very useful day today with the information that we have received from this session. I think for me, the question that was raised by Reverend Pastor Mwepi, it is a very important, question. But I think this study, for me, more so that it is done by one of the institutions of government, it's a very important study because if we don't have information such as this one, we will travel a road that we don't know where it is taking us and where we are getting to. So for me, I think it gives us a very important information, more so that we have limited resources, so that we can then make our minds and say, what are the best options, to pursue, to deal with the question of HIV and AIDS. I don't want to repeat what the findings are, but I think for me there were two areas that I think we need to pay attention to. The teenagers, the 15 to 19, as well as that cohort of 50 and above. I think that is where our efforts needs to be focused on, to ensure that they are virally suppressed. And I think it will contribute immensely to the reduction in the HIV AIDS cash. Anyway, I was called here to thank everybody who's here. Let me start by thanking our program directors for having done a sterling job. Let me thank all the presenters that have made their contribution to this meeting. Let me also thank all the implementing partners that are working with us in the province. I think we've had during the contribution by the various tables that they are doing some good work in the province. Let us also thank our development partners. I know they assist us a lot. I work closely with the Secretariat for the PCA. Most of the time they come and assist us with a lot of funding. Let me thank all the departments that are here for taking this HIV/AIDS program seriously. And then lastly, let me thank the Secretariat for having worked with the HSRC to coordinate this program. I think we have made it, we have exchanged the information, but I think this partnership doesn't stop here. We will continue to engage during lunch and even beyond lunch in our different platforms. Thank you very much, and I want to wish you safe travels as you go home. I'm not sure, Momokoti, where the lunch is being served, but I guess it will be at the restaurant, yeah. Thank you very much.